Assalamu alaikum. I'm Dr. Mohammed Shoaib for PIMS, and it is a great honor for me to present in front of my teachers. I will try to cover guideline-directed medical treatment of coronary disease, chronic coronary disease, in 10 minutes. So it's a multidisciplinary team-based approach. Not only the clinicians, but the dietitians and the other specialities, they contribute in treatment of chronic coronary disease. We have to focus on reducing major adverse cardiovascular events, including myocardial infarction, stroke, and mortality. And we have to address the comorbids, which will, in addition to these, they also reduce the mortality. And in the end, we have to take care of the angina. So statins are the cornerstone of treatment of chronic coronary disease. We have a data of more than 1.7 lakh participants that show cardiovascular event reduction with intensive statin therapy. And this is the effectiveness of high-intensity statins in reducing the LDL-C. You can see that there is a significant decrease in LDL-C, and this translates into cardiovascular risk reduction in most of the trials which were done on statins. So, but even with all this risk reduction, we have some residual risk reduction, about 21% to about 9% in some trials. And the cause of this is that we can even decrease the LDL even further below 70 to get some more risk reduction. And there are some other atherogenic particles like apolipo-A and lipoprotein A, which can cause further increase in ASCVD risk. So we need some other classes of lower lipid lowering agents, and among these we will discuss the bempedoic acid, isopent ethyl, and we will discuss PCSK9 inhibitors, inclisiran, just in some few slides. So ezetimibe has shown risk reduction when combined with statin, and it has a very well tolerated safety profile. The PCSK9 inhibitors have also shown ASCVD risk reduction about 15%. Evolocumab has shown this in Fourier's trial, while alirocumab has shown this in Odyssey trial. And then we have the bempedoic acid, which also have shown some improvement in the LDL-C in patients with chronic coronary disease, but the long-term outcome trials are still awaited. Same is the case with inclisiran. We have some trials with reduction of LDL-C, but long-term outcome trials are awaited for this. And icosapent ethyl is a drug which is used in hypertriglyceridemia in patients with chronic coronary disease, and it has shown reduction in mortality. So these are the guidelines. In patients with chronic coronary disease, high-intensity statins, which decrease the LDL level to less than 50% of the baseline, they are class 1 recommendation. And if they are not tolerated, then we can go to a moderate-intensity statin therapy, with which we can decrease the baseline LDL level to 30 to 49%. So if the patient with chronic coronary disease are judged to be at high risk, and even with the high-intensity statins, the LDL level doesn't come below 70, and the non-HDL cholesterol level doesn't come below 100, then we can use ezetimibe in combination with the statins. And in patients with chronic coronary disease on maximally tolerated statins with the LDL level greater than 100 and persistent triglyceridemia, we can use icosapent ethyl as 2B indication. So in high-risk patients, we use maximally tolerated dose of statins, and if we are unable to achieve the required decrease in LDL, we add ezetimibe, and even then we add the PCSK9 inhibitors, and if the patient is having triglyceridemia, we add icosapent in this regimen. So who are the high-risk patients? So the patients who have multiple ASCVD risk events and or one event with two high-risk conditions. The high-risk conditions are the age more than 65, hypercholesterolemia, which is of familial origin, and then diabetes, hypertension, chronic kidney disease, tobacco smoking, and persistent elevated LDL-C level in spite of maximally tolerated statin and ezetimibe therapy, and history of CHF. So in patients with the chronic coronary artery disease on maximally tolerated statins who have LDL-C level greater than 70, and in whom ezetimibe and PCSK9 inhibitors are insufficient and non-tolerated, then we add bempedoic acid and inclisiran, but the class of recommendation is 2B because we don't have any outcome data yet. So we also have to address the risk factors. We have to decrease the blood pressure below 130 and below 80. Diastolic. To do this, we first have to employ the non-pharmacological strategies, and once failed, we have to, in addition, add first-line therapy, which include ACE inhibitors, angiotensin receptor blockers, beta blockers, and if we need further optimization of BP, then we add calcium channel blockers, long-acting thiazide diuretics, and mineralocorticoid receptors. So we use SGLT2 inhibitors and GLP-1 inhibitors in type 2 diabetes, which is a class 1 indication. It reduces MACE, and if there is LVF of less than 40, GLT2 inhibition is a class 1 recommendation. And in patients who have EF of greater than 40%, we use SGLT2 inhibitors with benefit of lesser hospitalization, improved quality of life in spite of diabetes status. This is a two-way recommendation. So weight reduction management is also important, and we have a drug which is GLP-1, and we prefer semaglutide on liraglutide because of many trials, one of which is STEP HF Preserve EF trial, in which there is improvement in the symptoms of heart failure, as well as there is a decrease in weight. And it is done by multiple mechanisms, which I've already discussed in previous lectures. So the other main pillar is the antiplatelet therapy in patients with chronic coronary artery disease. In patients with coronary artery disease who doesn't have any indication of oral anticoagulation, low-dose aspirin is indicated, class 1 indication. In patients with coronary artery disease with PCI and dual antiplatelet therapy is recommended for 6 months, then followed by single antiplatelet therapy, class 1 indication. But if we want to reduce the dual antiplatelet therapy for even lesser time, it becomes a two-way indication, and we follow it up with clopidogrel for the rest of the duration. So in patients with the chronic coronary disease who have previous MI and at low risk of having bleed, we can continue DAB for 3 years. That will reduce MACE. And in patients with chronic coronary disease without recent ACS and PCR-related indications of dual antiplatelet therapy, the addition of clopidogrel to aspirin therapy is not useful to reduce MACE. So this is the same flow chart. And then we come to the COMPASS trial, which showed there is a reduction in MACE when we use rivaroxaban, low-dose rivaroxaban in addition to aspirin. And this is reflected in the guidelines as well. In patients with chronic coronary disease without an indication of therapeutic novel anticoagulation and DAB, we are at risk of recurrent ischemic events, but low to moderate bleeding risk. And the addition of low-dose rivaroxaban 2.5 milligrams twice daily to aspirin daily is reasonable for long-term reduction of risk of MACE. So these are the recommendations for beta blockers. If the patient is having EF of less than 40, or there is history of myocardial infarction, the recommendation is class 1. And but if the patient is having, if the patient is not having any LV dysfunction, then there is a dilemma. We can use the beta blockers in patients with moderately reduced EF. That has been supported by pretty much large registries, and but few trials are going on which will give us the insight about the use of beta blockers in patients with who are not having any LV dysfunction. In patients with coronary disease who are initiated on beta blockers for previous myocardial infarction without a history of or current LVEF less than 50, angina, arrhythmias, or uncontrolled hypertension, it may be reasonable to reassess the indication at 1 year. So these are the guidelines for addition of renin-angiotensin aldosterone inhibitors. If the patient is having EF of less than 40 or history of CKD or history of diabetes, then there is a class 1 indication of adding RAS inhibition. And if the patient is not having any hypertension, diabetes, CKD, and EF is greater than 40, then it is 2B indication. So this is the use of colchicine in coronary disease. In this trial, they given the colchicine to patients who have underwent MIs and followed them with the OCT. And what they saw was that there is a thickening in the plaque, which will cause plaque stabilization. And this was also seen in the meta-analysis, which showed decreased number of myocardial infarctions, but the cardiovascular death there was no significant difference. So the recommendation of colchicine, addition of colchicine for secondary prevention may be considered to reduce recurrent ASCVD events. Then we talked a little on the anti-anginal therapy. The beta blockers, long-acting nitrates, dihydropyridine, calcium channel blockers, these are the first line of treatment. If the patient doesn't improve with these, we add another agent from the same group. And if still the patient is having anginal symptoms, we add either trimazidazine, ranolazine, or we can give combination of these. So in patients with coronary artery disease and normal LV dysfunction, the addition of ivermectin to standard anti-anginal therapy is potentially harmful, because we have already seen in Signify trial that there is no difference in mortality. Rather, the number of mortalities in patient having ivermectin was more, even though the ivermectin was giving some anginal relief to the patients, but the mortality was more. So it is a class 3 indication for using ivermectin in patients for anti-anginal therapy. This is my last slide. Thank you.